Hello, everybody. Welcome to my channel, Medicine in a Minute. I am a doctor and consultant of medicine, and I am here to simplify medicine for you in a minute. So, let's get started. So, the topic I've chosen for you today is oral anticoagulants. There are a lot of IV anticoagulants also, that is known as heparin and low molecular heparin, but that is a very different topic to be discussed in detail later. Today I'll be dealing with the oral anticoagulants, and we have two groups in it. One is the vitamin K antagonist and the other one is non-vitamin K antagonist. So the vitamin K antagonist we have is the old and the tested one, which has been going on for years and years, is the Warfarin. And here non-vitamin K antagonists include direct thrombin inhibitors and factor 10A inhibitors. Direct thrombin inhibitors is only Dabigatran, and the other one, factor 10A inhibitors, are Rivaroxaban, Apixaban, and Endoxaban. Dabigatran is also known as Pradaxa, and Rivaroxaban is also known as Xarelto. Apixaban is also known as Eliquis. Endoxaban is not so much in use. The most frequently used amongst these are Dabigatran, Rivaroxaban, and Apixaban. So we'll deal with each of these in detail. So I'll begin with the Warfarin one. Coming to Warfarin. Warfarin is, as I've already told you, is a vitamin K antagonist, and it deals with factor 2, 7, 9, and 10. Okay. So, but it is very cheap drug, most commonly drug, but it comes with its disadvantages also, because it has a lot of drug plus food interactions. So whenever we put patients on the Warfarin, we tell them not to have green leafy vegetables because it tends to affect the INR, and it also requires a lot of monitoring with respect to INR, which needs to be checked weekly or monthly. The bleeding risk is also quite high with Warfarin. The onset of action is also very slow. In 1 week you can see the onset of action. Coming to the reversal of Warfarin, if patients are on Warfarin and tend to have a very high INR, and you have to judge like what to give them for the reversal of this high INR, and there's a risk of bleeding in the body, we have vitamin K antagonist. Vitamin K injection, I'm sorry for that. Vitamin K injections. Vitamin K injection is given as 10 mg of IV over 10 minutes. That comes up to like 1 mg per minute. And then you can repeat your INR and see if you have reached your therapeutic range. And you can repeat INR next day also, and usually we give it for like 3 days to reverse the range of to reverse the INR and bring it down to the range. So coming down to the other novel anticoagulants, that is NOACs as we know it. The N here stands for novel. Oral anticoagulants, as I've discussed, this is Dabigatran, Rivaroxaban, and Apixaban. Okay, so Dabigatran, although all these drugs are a little expensive, but they have the advantage of not so bleeding and quick onset of action. quick onset, and they do not require so much of monitoring, not requires monitoring as it is required in warfarin. So we'll deal with each of these in details. The Dabigatran is used when a patient is at risk of forming clots in their body. Either there's a hip or knee surgery, or a patient has atrial fibrillation and there's a risk of stroke or malignancies. All these requires the patient to be put on blood thinners, or any DVT prophylaxis also is required in any patient. And also they can be used as a treatment for pulmonary thromboembolism and treatment of DVT also. So this is the indication of Dabigatran, all of these. So when you know the indications and you want to start the patient on any of this medication, Dabigatran, also known as Pradaxa. So it comes in 2 doses based on the creatinine clearance of the patient. You put the patient on either 150 mg of BD twice a day if the creatinine clearance is more than 30 ml per minute, and if it is less than 30 ml per minute, then the dosage is 75 mg of BD. So among all the NOACs have a BD dosaging, but only Rivaroxaban is only OD. Other than that, all are BD. So now you have put the patient on Pradaxa and he's doing well. You don't require INR monitoring as such. But then you find something somewhere bleeding in the patient, and it comes with the bleeding when the patient is on Dabigatran, and then you get the PTNR done for them, and you find that they also have deranged creatinine clearance. Some AKI has occurred, and then they have started accumulating Dabigatran in the body. The metabolism is affected because Dabigatran is primarily excreted by the kidney, and whenever the patient has AKI or any kidney injury, they tend to accumulate Dabigatran inside, and then they'll end up with bleeding tendency. So now you want to revert these bleeding. So what do we have at hand is only 2 of these. The most specific one is Dabigatran. Dabigatran is a monoclonal antibody which is given at a dosage of 5 grams of IV. Okay, but then this is very costly, like it is in lakhs in India. So it is rarely available in the pharmacy to get your hands on. So what we have at hand is PCC. PCC is also known as prothrombin complex concentrate. This is easily available in your hospital, so you can use it at a range of 50 international units per kg IV single dose, only to reverse this bleeding that has occurred with Dabigatran. You do not to use FFP and not to use vitamin K, because it won't help you. FFP, although you can use sometime in rare emergencies when you don't have either PCC or Dabigatran, but then it is only for like a fluid resuscitation sort of thing it will do, but not so much of a help over here. The other things that we will be dealing with here is Rivaroxaban. Rivaroxaban is also known as Xarelto. The indications are same over here also, like a hip or knee surgery. So you want to give thromboprophylaxis in hip or knee surgery, or DVT prophylaxis for them. So it is the advantage of Rivaroxaban is an OD dosing, Now here also you need to see the creatinine of the patient. It depends on the creatinine. If creatinine is more than 50, creatinine clearance, although more than 50 ml per minute, it has dose of 20 mg OD, or if it's less than 50, the dosage is 10 mg OD. Now Rivaroxaban also doesn't have a reversal dosages. New ones that is available here is Andexanet. You just have to remember the name because it is rarely available in any of the hospitals. The other one that we have is Eliquis. Eliquis is also known as Apixaban. Rivaroxaban and Apixaban both belong to the group of factor 10A inhibitors. These are 10A inhibitors. This also is factor 10A inhibitors. The indications remain the same. If you want to choose among Dabigatran, Rivaroxaban and Apixaban, Apixaban is rarely mostly favored, among Dabigatran, Rivaroxaban and Apixaban. The dosage is also very good, but although here also it depends upon the creatinine. If it's more than 1.5, then you have to give 2.5 mg BD, and if it's less than 1.5, that is a normal creatinine actually, the dose is 5 mg BD. So here also, if any of your patients is either on Rivaroxaban or Apixaban and they come with the bleeding because they have raised creatinine or AKI, then you have two things at hand, or maybe one thing only. You have PCC only to reverse that bleeding. Dosage as I've already discussed. So I think I have covered all the oral anticoagulants in detail. That is Warfarin. Then here we have Dabigatran, Rivaroxaban and Apixaban. And this is now usually favored because of the dosaging and then the not so much of requirement of the INR per se in these medications, and among these also Apixaban is a little bit favored. So I hope I've cleared all your doubts. Thank you so much.